Is it self-harm or is it suicidal ideation? Is the person harming themselves for a purpose other than ending their life, or do they truly want to end their life? And is self-harm even the right term? Is that the term we should be using? Well, I'm Dr. Virginia. I'm going to give you some new terms that I want you to be thinking about. Okay. Now, self-harm. We used to call pretty much everything self-harm, and then it was self-injurious behavior, and then it kind of evolved into a variation of what we now call um, uh, self-directed violence, right? Or violence against the self. These are all terms that we have used for a person that might want to inflict damage to themselves. So you might be asking, well, what's the purpose of it? That is exactly what determines whether it's self-harm or SIB, self-injurious behavior, versus suicidal ideation. Suicidal ideation is a person that wants to unalive themselves. What's the main difference? It's the purpose behind it. So self-injurious behavior, self-harm, a self-directed act of violence. The purpose usually, from what I've heard from patients, this is actually talking from patients and the data actually supports this, there are a couple things, and it's kind of been boiled down. I have a very common sense approach to medicine, at least that's what I've been told by my supervisors. It boils down to three things, one of three things. Number one, it could be because the person just has such a flat affect, meaning that they're not feeling anything and you're not noticing anything in terms of their emotions on their face. And that's also reflected internally. They're really not feeling very much on the inside. I've had people say, I just feel empty or dead or just stagnant on the inside. And the act of doing something to themselves to hurt themselves actually helps them feel something. So they go from being completely numb to, oh, at least I feel something. Yes, it may be painful or uncomfortable to some extent, but that lets me know that I'm still alive. I'm not completely numb. I'm not this ghost of myself. I'm not just this shell. Second reason might be they feel too much on the inside, a lot of tension, a lot of pressure. And I've had people say, well, doing something to harm myself, it's almost like I'm releasing pressure. It's like a pressure valve is going off, right? If you've ever had a pressure cooker, an actual authentic old-fashioned pressure cooker, it's got a dial to tell you the pressure, but it also has something like a release valve. Either there's a little valve that you can open up, or there's a lid that you can unscrew or flip, and that will allow some of the pressure to evaporate. Well, if you don't have that, literally, that pot, if there gets too much steam, if it gets too much air pressure on the inside of that pot, it can actually do some significant damage in and around it. So, release of pressure is another thing. The last version that I've heard of, well, why would a person want to harm themselves? The last version is, well, I'm in control. Previously, in an extent of trauma, someone else was in control. He hurt me, she hurt me, they hurt me. And they were in control of the pain that was inflicted. Well, now, guess what? If someone's going to cause pain in my life, let it be me. Let me be the person that controls that. Okay? And I'm not sure if that is resonating with anyone that's watching. If it is, if you don't mind putting in the comments, yeah, I get that. 1, 2, 3. Yeah, that kind of tracks with me. Other thing is, if you're noticing that you're having these experiences and you're struggling, there is help. There definitely, we wanted to see if we can treat the root cause of whatever is going on. And there are quite a few modalities that can be helpful. Of course, if a person's dealing with more personality concerns, like borderline personality disorder, DBT is phenomenal. But guess what? Even if you aren't dealing with personality concerns, if you have a significant history of trauma and you're struggling in this area, DBT is still helpful. Let's say you don't have a significant struggle with trauma, but you are struggling in your relationships, or you are struggling to self-regulate, to regulate yourself. DBT can still be helpful. DBT is dialectical behavioral therapy. It's a spinoff of cognitive behavioral therapy. Most of the major therapies that we use right now are a spinoff of CBT, or cognitive behavioral therapy. And DBT, I think, are just basic life skills. They're just basic dealing with life, dealing with stressor skills. So whenever I have an opportunity to recommend it, I actually will do that. Let's say you're already doing that, you need a step above that. Well, certainly medications can be helpful. There are quite a few medications. Now, it's symptom based. If you're feeling that intense pressure, maybe it feels like a lot of anxiety. I've had people say they just feel like there's energy, too much energy on the inside, and they just too much. They just feel overwhelmed. If it's in that anxiety realm, then yeah, we might use a medication that's an anti-anxiety medicine or an anxiolytic. There are some that were created to be that, Boost Bar, plus some of the benzodiazepines, and then there are others that we were created for one thing, and then it's like how what psychiatry does. It was created for something else. There's some benefit, so we're gonna adopt it. But honestly, this is kind of in our ballpark. Antidepressants were created for depression within the realm of psychiatry. However, if you go higher doses, slightly higher doses, usually it also helps with anxiety. So Paxil, antidepressant, moderate to high doses, great for anxiety, as an example. Effexor, wonderful antidepressant, at slightly higher doses, can be good for anxiety, among other things. So I'm hoping that has kind of helped give you an idea about self-harm versus SI, or the thoughts to harm the self. For SI, I do want to say this very quickly. There are levels, right? And when we assess a person, we're going to ask them, are you at immediate risk, imminent risk, danger? Meaning, if no one were to stop you right now, you would go and do something to harm yourself, to end your life. Or even if someone's here, as soon as that person is a few steps away, you're going to do something to end your life. Another thing to think about is the person that says, well, no, I wouldn't do anything, but the thoughts are still there. The thoughts are still plaguing me. All of those are reasons for treatment, every single one of them. Now, the type of treatment, the tiered treatment certainly is going to differ depending on how at risk you are. If you're at imminent risk and you're thinking about hurting yourself and you've got a very lethal plan and you are going to try to do something, whether people are around or not, we're going to likely say hospitalization is the best thing for you. It's the safest thing for you, safest thing for your loved ones and family, right? If you're saying, no, I really don't want to do anything to harm myself, and you're legitimate about this, I really don't want to harm myself, but there are times that I feel unsafe. Well, that's when we come up with something called a safety plan, where we help you make your environment, we help you make your body and the things around you safe so that you can return home potentially. Okay, so those are two kind of different ends of the spectrum, hospitalization and hospitalization. We've talked about this before, that not everybody needs to be hospitalized. And hospitalization, especially for certain groups, can make things worse. So I'm always very careful about whether or not I make a recommendation for someone to go to the hospital. Okay, so yes, even if a person does have thoughts that, life is not worth living and they'd be better off not alive, doesn't necessarily mean that I'm going to put them in a hospital or try to force them to go to the hospital. Honestly, I truly want them to make the decision for themselves if they want to or not. I'm just a partner in the conversation. Yes, I've told people that they've had to go whether they wanted to or not, and have made decisions for them. I very much prefer not to do that, very much so, because my hope is I'm going to still be your doctor when you leave the hospital so that we can work together and help you feel better. It's very difficult to work with somebody that you don't trust, that you feel like is just going to, discard you and throw away the key. And I never want anybody to feel that way. I want you to know that we're partners in this journey towards help. Okay? Well, again, your call to action. If you know someone with self-harm and you're unsure if they're getting the proper care or treatment, have a conversation with them about it. If you yourself are dealing with that, give me the 1, 2, or 3. Legitimize what I've been saying. Make sure I'm in the right ballpark. And if you're having thoughts to hurt yourself, please know, as I shared in the last video, there is hope. There are so many treatments that are helpful for you. The 2 that we use in our office, almost knee-jerk reaction, a person has suicidal ideation and it's significant and it's real. And they're telling me it's real, right? It's not, oh, I told somebody this just to get out of work. People do that. They've told us that they do that. If it's real and it's legit, it's bravado TMS. Like knee-jerk, because they work. Why would I not want to go with things that work, right? Low risk, high reward. It works. Okay? All right. Well, you guys have a great night on purpose, and we will see you next time. Take care.